Up next, we have Dr. Jayasree Gajaraj talking on the topic multidisciplinary care in obstetrics. Ma'am is a senior obstetrician and gynecologist from MGM Healthcare, Chennai, with more than 40 years' experience in the specialty. She has a special interest in high risk pregnancy care, especially the management of diabetes and hypertension in pregnancy. And she is a skilled surgeon specializing in hysteroscopic surgery and gynae laparoscopy and oncology. Welcome, ma'am.
Thank you very much. I'm sorry about that intro. I think that's a download from promotional work at MGM. I'm sorry about that. Thank you very much for inviting me to be part of Advances once more. It's an event we all look forward to. MDT in obstetric care. I think when we talk of MDT, what comes to our mind is always an acute situation where everybody is going to be running around trying to do something, not knowing what to do. But what is important to realize that MDT is not necessarily always an acute or a critical situation. Even in routine antenatal pre-pregnancy care, we do need MDT care. And I'll be trying to take you through some of the situations where MDT will be useful and what is the principle behind multidisciplinary care and management. It's actually a coming together of professionals from diverse disciplines with a wide range of services and sectors which are available within that unit in that hospital. Most important, to work together to improve patients' health and well-being. That is the aim of MDT. So therefore, a holistic approach to the situation has to be comprehensive, it has to be defined earlier, has to be very well coordinated, and how it helps is by enhancing decision making. So generally, an MDT in the obstetric scenario would consist of most certainly an obstetrician, and midwife to begin with, obstetric anesthetist, an obstetric physician or a physician dedicated or committed to care of medical disorders in pregnancy, a specialty surgeon, often we do take help from them, and a neonatologist and an intensivist on board. In addition to this, the family physician or the general practitioner who takes care of the woman should also be on board at some point in the decision making. And not to forget our allied health professionals who always give us a hand very silently in the background. But the team has to be led by a named healthcare professional. And when I say named, it just have not loosely termed as a senior obstetrician or a senior physician. You need to have a name behind that designation. And that person has to be committed and has to be available 24/7, 365 days a year, unless they are going somewhere. And the responsibility has to be handed over to an equally capable person when they are not on the scene. And the main role of that person is they should be responsible for facilitating communication and coordinating the care. So as I said, antenatal care. What happens when we have a pre-existing maternal condition? Key risk factor for adverse pregnancy outcomes for both the mother and the baby. And it was found in the confidential inquiry that indirect causes, that is exacerbation of new onset of medical or psychiatric illness during pregnancy, accounted for almost 2/3 of maternal deaths. And it's commonly seen are diabetes and cardiac disease in pregnancy. So we have to speak about MDT. It's applicable in the scenario of a preconception care as well. Very, very important, and I think it's gaining a lot of importance now. In the antenatal scenario, intrapartum, not to forget postpartum care, and more often nowadays, in an emergency obstetric care situation. So MDT actually spans the entire spectrum of obstetric care. The NICE guidelines, they say that women with pre-existing diabetes, now as soon as you diagnose diabetes, that during the pregnancy for the first time, or if you know this is a woman with a pre-existing diabetes, you immediately refer them to a joint diabetes and antenatal clinic. The National Inquiry into Diabetes in Pregnancy, they have said that the minimum team composition should be an obstetrician, diabetes physician, a diabetes specialist nurse who plays a very important role, and a midwife. Important also to get a dietitian on board. Now, what about pre-existing cardiac conditions? The European Society of Cardiology, they have said high-risk patients should be treated by an MDT in specialized centers only. The RCOG says that all women referred initially for risk assessment by a core MDT. And this initially would mean really at the very beginning, as soon as you know it exists. Obstetrician, cardiologist, and anesthetist, along with midwives, neonatologists, etc., wherever appropriate, you need to bring in the specialists. Somebody with overt diabetes, starting off with preconception care, we need to have an MDT in place even at that time. One, to create awareness and education, because this lady, when she's planning a pregnancy, needs to know what is in store for her. Specialist care, she has to come and meet a specialist, get their opinion, and it should be part of her decision making. Important to rule out retinal complications and renal complications in overt diabetes before she plans a pregnancy, or at least to assess the situation before she does it. Once gestational diabetes is there, then you have a joint clinic where both the diabetologist as well as the antenatal care physician comes on board. When you need to look at the anomalies and the growth scans, we're talking of fetal medicine specialists coming in. And certainly at the time of delivery, the anesthetist and the neonatologist also have to join the team. Chronic hypertension, again, pre-pregnancy. Both the physician and cardiologist need to play a major role. So they have to know, the woman has to consult somebody before she gets pregnant. Change of medication, for example, she may be on ACE inhibitors or ARBs. They are known to be associated with congenital anomalies. So the physician or the cardiologist taking care of her has to switch over to alternative medication, has to ensure control before they actually give her the green signal to go ahead with pregnancy. Similarly, patients who are on thiazide diuretics, very important, many of these women are obese, so we need to tutor them on weight management, exercise, diet, etc., and optimize her general condition before she gets pregnant. PIH and preeclampsia, again, very, very common. We are dealing with it almost every day in our practice. Here again, apart from us, even during the antenatal period, if her blood pressure is not controlled, or in the ideal situation, even to take care of her blood pressure, we probably need a physician, sometimes a cardiologist on board. Fetal medicine specialists certainly to pick up growth restriction, so they are again with us on the team. When complications occur like a cerebrovascular accident or eclampsia, the intensivists, the hematologists, and all, the nephrologists all have to come on board. So day-to-day practice also, not necessarily when she develops a complication, but even when she is with us during her pregnancy with PIH, we need to take care of her. Sepsis is gaining a lot of attention these days because I think in this scenario in 2025, we cannot afford to lose an antenatal mom to sepsis. So we may be concentrating on diabetes, hypertension, etc., but sepsis is something that exists, that does loom high, and we have to be able to control it. So for this, we need an ongoing MDT review, and definitely a named lead in every hospital, in every unit has to be there. Apart from the obstetrician, anesthetist, neonatologist, we need a good microbiology team who will give us enough input on what antibiotics should be used or not used. Are we changing our antibiotic policies regularly? Are we adhering to prophylactic antibiotics in the right way? Or across the hospital, across specialties, do we have a misuse of antibiotics? Very important to take cognizance of all this. And then we have always a senior midwife, again, dedicated to the care of these women. Very, very important is a labor ward coordinator, a medical or a non-medical person who is able to direct this woman where she needs to go, or rather direct the referrals and ensure that the senior people come in and see this woman so that her treatment can go on. The senior intensivist has to take care of this woman with sepsis in labor, mainly because they need to look at the following: altered consciousness, hypotension, systolic blood pressure less than 90, reduced urine output less than 0.5 ml per kg per hour. Not just look at the bag and say it's reduced urine output. Need for 40% oxygen to maintain an oxygen saturation above 92%, and a temperature of less than 36 degrees. So what is important in obstetric sepsis is that the scenario can actually evolve very rapidly, very much under our eyes, even as we are looking at the woman. So we need to be aware of what can go wrong and preempt investigation and treatment to some extent. Moving on to the other critical situation of placental abruption, we know that a whole host of complications can come up in placental abruption, severe hemorrhage, acute kidney injury, maternal death also, prematurity, which can again be a factor to deal with, a rapidly evolving coagulopathy, DIC, just again in front of our eyes, massive transfusion, and along with it, transfusion-associated complications, sometimes even require major surgery like a hysterectomy in an unplanned situation. So the increased risk of cardiac events have been reported in women with placental abruption. So almost every organ can actually then be involved. So what do? It's actually a true obstetric emergency, and it has to be managed by an interprofessional team of healthcare professionals. So everybody has to descend on the scene as soon as possible. A triage nurse who plays a very, very important role. They are the people who actually see the woman as she walks in, admit and notify the emergency department physician. Immediate resuscitation has to start despite whether we are there or not. Transfer to an ICU setting, blood should be crossed and typed. So everything has to roll on one after another or one along with another. Collaboration between the anesthetist, radiologist, the OT staff should be informed and alerted. Premature fetus quite often, so the neonatologist and the team has again to be informed. So abruption is something again we are seeing not so uncommonly. So we need to have a protocol in place when somebody comes in with a suspected abruption. I find most of the time even a very high degree of clinical suspicion is important. I find nowadays a lot of our registrars don't think of abruption, which is sad because we are seeing it, we are seeing hypertension, so we need to be aware of this. Placenta accreta spectrum, a lot again is being spoken about this in the literature. Best managed when it's diagnosed antenatally. And I'm happy to say that our imaging colleagues nowadays give us enough information to diagnose this antenatally. And most of the time we are forewarned and we are well prepared when we plan the delivery. So the ACOGs, they recommended delivery between 34 and 35 plus 6 weeks of gestation. A cesarean hysterectomy to optimize neonatal maturity and minimize the risk of maternal bleeding. And now I think slowly people are beginning to talk about, should we go for a hysterectomy? Is there any chance of conserving the uterus? But that's probably a debate in itself. Important to have centers which are dedicated to taking care of placenta accreta spectrum. These are the Placenta Accreta Center of Excellence or the PACE centers. And if you don't have this in our city, a level 3 or a level 4 center for delivery where other facilities are available. Thank you. Team should include perinatologists, surgeons, intensivists, general surgeons, urologists. I think almost entire team has to be present. And in the few short series of about 9 cases that we have managed, the theater has been full. But I'm happy to say that we've done well on every occasion, mainly thanks to our interventional radiologists. And if the patient is bleeding, early transfer to an appropriate facility. If you are operating in a center where all facilities are not available, but underline the fact that please transfer these patients to a center with better facilities. Do not attempt to deliver them at lower level resources. Coordination with the blood bank, very important. Even prior to the procedure, you really need to make sure that enough blood is available. The interventional radiologist, as I said, plays a very important role. Prior placement of the catheter in the internal iliac artery, temporary balloon occlusion. Once the procedure is over, you can actually deflate, take out the catheter. Here, again, a recommendation that optimal management involves a standardized approach with a comprehensive multidisciplinary team. And that is what I think we need to emphasize on. The critical care situation. Here again, a lot is being spoken about critical care, critically ill pregnant women in obstetric and obstetrics. The need of the fetus here has to be kept in mind. She's pregnant, she's deteriorating, she's in a very critical condition. That fetus probably deserves and would like to go on, would like to live. So how best can we manage her at the same time salvage the fetus? Here care can only be individualized depending upon the gestational age, depending on the maturity of the baby, depending on facilities available, and how much time is available for us, because the mother always takes the precedence. Depend on the needs. You've got something called the needs assessment by the MDT has to be done. So they have a checklist which they go through, and then they tick off and decide whether we need to deliver her now or whether the baby takes a second step and the mother is more important. Postpartum, again, important because our midwives play a very major role once a woman is delivered, not only on the ward, but after she goes home as well. Lactation consultants, again, help the woman to continue lactation, help her when she has problems with lactation. Perinatal mental health is something we all ignore. We need to keep psychologists on board, not necessarily psychiatrists, because that's a word that most of our women will not like. But somebody who can walk into the room, smile at them, counsel them, and that is a very important person in the MDT, because that prevents her from going into postpartum depression, helps her to take care of her baby, and therefore contribute to the well-being of the neonate. Trauma is one situation again. 1 in 12 pregnancies, trauma affects pregnant women. Not so uncommon. Twice as likely to die, women are twice as likely to die or suffer from significant morbidity. So we are again seeing more of trauma in pregnancy nowadays. Earlier, I think our families at home said, don't travel by car, don't go anywhere if you're pregnant, stay at home. But now it's not so. Women are driving, women are there, and trauma is definitely something we need to keep in mind. That requires, again, an MDT approach, rapid assessment, treatment, and transport to optimize the maternal and fetal outcomes. So when you are transferring her itself, you know she's pregnant, try to transfer her directly to a center where all facilities are available. Not go to the nearest hospital and then lose some time and then go to the next. Because most ambulances now we know are equipped to take care of everything. What do they do? Now that's not a situation where we are going to think, should I call this person? Will this person be useful? We don't have time to do that. So we have MDT training using simulation for obstetric emergencies. And this is a drill that we all should be doing in our units. It doesn't matter what level of care we have. With the resources available, we should be trying to do these simulation drills as often as possible or at regular intervals through the year. This will help us to identify and correct common clinical errors that take place. Because after all, remember, anybody who is there in that situation, on the road, if there is an accident or a trauma at home or whatever, the person who is first on hand need not necessarily have all the information or they may not be empowered with the knowledge to take decisions. So as soon as they come into our purview is when we have to set the ball rolling. They allow team members to practice effective communication in crisis like this. So all this is put into a program and into a simulation drill, which we need to take care of. Here, what do? A unique emergency care needs of the pregnant patients. They are taught about all this. They are taught to identify latent safety threats. That is very, very important. Clarify, evaluate, revise existing protocols at regular intervals so that we are up to date with the management. And it will definitely improve the confidence. So this is just to tell us again the care pathway of the deteriorated ill patient, critical ill patient. First step is detection of clinical deterioration. That's important to pick up. Then the response, provision of a MDT care plan with obstetric interventions, level 2 critical care in a delivery suite or a maternity unit, or even in a HDU if that's what we have, and then, if at all possible, transfer her when time is appropriate to a critical care unit. So the nice guidelines, they again, I may not go through all this for lack of time. I'll take 30 seconds extra. Is that okay? Right. So it's important, we need to know the rationale behind this nice quality statement that they have brought up. And specialist advice is very important. More than one expert may be involved at times or may be needed at times. Designating a named healthcare professional to lead the team. Again, I'm repeating this because most often we don't know who is the leader for that team. So we need to know, this is so-and-so, this is the phone number of this person, this is how they'll be available. And that has to be very well posted on the labor ward. The structure of the whole process that we have in place, there has to be evidence that MDT team caring for pregnant women with existing medical conditions can access expertise. So within the unit, who are the people who will come on board as soon as we call them? Again, a named healthcare professional is available to lead the team. This is what all the guidelines are repeatedly telling us. Service providers, again, protocols have to be in place. Healthcare professionals, named healthcare professionals takes responsibility to lead the MDT. And you have people who can ensure protocols are in place, because we will be busy running around with the clinical work. There has to be somebody around who is just monitoring the whole thing and seeing if the treatment plan or the management plan is going according to the pre-planned process. And whenever medical conditions are present, then the appropriate person has to come on. So if we were to ask ourselves, do we all work within a team? I'm sure all of you will say yes, because we do. But how effective is this team? Can this team come together when we need, just at the flick of our finger? Will they be there? I think not. So we work within a dysfunctional team. So dysfunctional teamwork is not our aim. We should try and put together a protocol in every unit, given our resources, what is available, so that we can manage this woman, we can step up care, we can refer her to a higher center of care when required. Thank you very much.
Thank you, ma'am, for that insightful session and reminding us how this collaboration is truly elevating the outcomes for both the mother and baby.